DigiPath Digest, and we're starting with figuring out the PDF. Okay, immunohistochemical biomarker scoring in gastroesophageal esophagus. I don't know how to pronounce esophageal. Esophageal cancer. I don't think that's the correct pronunciation. Can computer help us? So, if you've heard me speak ever, you probably know I have a very strong opinion on scoring visual IHC and in generally like visual scoring system. And my strong opinion on that is it's guesstimation. So if you can get a computer to help you, please do. So what happened in this particular publication was that obviously the scorings are increasingly complex, but still the expectation is that the pathologist is going to do it, is going to score. So increasing complexity of cancer diagnostic has placed a growing burden on pathologists. I know when I hear about scoring, I'm sad because I know I'm not going to do a good job. It's going to be a guesstimation, especially evaluation of IHC biomarkers. And in this case, they were focusing on the phageal esophageal cancer, both adenocarcinoma and squamous cell carcinoma. For this particular cancer, GEC, there are multiple prognostic and predictive biomarkers, and this meticulous scoring is difficult, time-consuming, and suffers from inter and intra-observer variability. This is the thing that I dislike for those scorings, very subjective. Often it's the best we can do, but a computer can do better. And we don't have enough pathologists to sit there and score. So the potential solution would be AI. Can AI help us in IHC biomarker scoring in GEC, gastroesophageal cancer? And they did a search in PubMed and Google, and by they didn't introduce the authors. Here, this is a group from Italy, Alessandro Caputo et al. And this was in Pathology Research Practice. So what they did publication search. They did a search, and there was promise of AI for PD-L1 and HER2, but that's not something you would always have in GEC, and the applications in GEC remain limited. Well, let's develop some algorithms then for GEC. But the conclusion here is that although there are several algorithms for scoring IHC, and there are not so many in GEC, and AI would help us by alleviating the burdens of complex scoring systems and costly additional assays. So if we had, that would be fantastic. We don't have that for GEC. So if somebody is working with the GEC, please develop it. Let me know if you're working in GEC. Okay, but now let's talk about the potential use of AI for atypical small acinar proliferation in prostate core biopsy. So ASAP. And for prostate. So what is that even? Prostate cancer is the most common diagnosed cancer and also second leading cause of cancer death in the US. And the gold standard is examination of tissue from a symmetric 12 to 14 core biopsy procedure by an anatomic pathologist. And there is something called atypical small acinar proliferation. And this is considered an indefinite diagnosis and may cause difficulties in clinical management. So you basically don't know, what's going on, right? It's atypical small acinar proliferation. In this particular publication, what happened was that the authors who were, I don't know which institution because I have a different printout, but this was in archives, and the authors did use AI to check against the pathologist. So what they did to investigate potential use of AI in this ASAP case, they used Page Prostate. Page Prostate is the FDA-approved AI-based digital pathology system, and it was used on images of 107 cores with an initial diagnosis of typical small acinar proliferation. So I have my questions about this study design or what they gained with this exercise, but they used the page prostate and they had two pathologists blindly reclassified the course with a new diagnosis, benign or malignant. This is something I don't understand. If you understand, please let me know, because they had this atypical small acinar proliferation. So they it was an indefinite diagnosis, and then they reclassified and were forced to decide whether it's malignant or benign. Okay, but anyway, they decided that it was either benign or malignant for 85% of the cases for pathologist 1 and 88 pathologist 2. So I guess in the remaining cases, they didn't reclassify. And page prostate resulted in diagnosis that was consistent in 85% of the course. So prostate doesn't say malignant, benign. Prostate page prostate says suspicious and not suspicious. And then so it was consistent in 85% of the course. And the consistency rates were here 75 between the two pathologists and 67 between the two pathologists, and 66 and 75 between page prostate and each pathologist. Yeah, we are in the high 70s with one pathologist and the high 60% concordance. Yeah, I always say that if the pathologists agree a lot, it's like 70%, but in the 30% of the cases, they don't agree. So does not surprise me. But there was some degree of inter-observer discrepancy still, and the findings indicate that artificial intelligence was compatible with pathologist review. So here my question or reservation is, but did you then somehow check with a different method? Can you even check for this? Because to me, it's the page prostate goes against pathologists that are classifying something that is difficult to classify. I don't know where the added value is. The good thing is that page prostate performed as similar to the pathologist, so that's good. But that was my reservation about this one. I would want to see, and I don't know if there are orthogonal methods to do this, but I would want to see, okay, then they stain these atypical acinar proliferation for some maybe basement membrane disruption marker. There are markers that can, the IHC markers that can tell you if it's benign or malignant. And then compare this to the pathologist reclassification and prostate. So I don't know, they didn't do it, or maybe I'm just misinterpreting something. Next paper. Let's do it, guys. We have a paper about the development of a machine learning-based model to predict urethral recurrence following a radical cystectomy. This was a multi-center retrospective study and updated meta-analysis. So retrospective study with real cases and literature search meta-analysis. Particular thing, and no image analysis was used. That was machine learning trying to compute a predictive algorithm. So urethral recurrence following radical cystectomy for bladder cancer represents an aggressive disease failure, and it typically results in poor survival. And so they tried to predict risk factors for this recurrence, urethral recurrence, to develop and validate an easy-to-use predictive tool for this recurrence, urethral recurrence in the region. And in the region, this is in China. This is a publication from China. And I highlight this easy to use because yesterday I was trying to find a software for reference management and AI-based software. I tried like 3 different ones and then went back to Perplexity, who invents publications. So I couldn't use that one for reference management to ask, hey, which one is the easiest to use? I found one. I will report once I have that publication finished. So anyway, so clinical pathological data from the patients who underwent RC, radical cystectomy, between 2010 and 2020 were analyzed. And they wanted to confirm independent risk factors for urethral recurrence. And they did univariate and multivariate Cox regression to check that. They did an internal validation. They had a data set train and data set to test. 80% of the data points was for training and then 20% for testing. And they developed this predictive model using the machine learning algorithms and evaluated the model performance by area under the ROC curve, also accuracy, sensitivity, and other metrics like F1 score, Breyer score, and C index. F1 score, I'm familiar from image analysis. And the best performing model was selected. And they used so-called SHAP method, shapely additive explantation method, to calculate the contribution of each feature to the machine learning prediction. And they had several features that contribute. So let me show you what these features were. They had, and also then they added the PubMed and Embase and Scopus databases for publications. And they had 473 patients, and they analyzed with they were analyzed with a recurrence rate of 8.24%. And then there was also concomitant carcinoma in situ, tumor multifocality. They were demonstrated to be independent predictors of recurrence or urethral recurrence. So concomitant carcinoma in situ, tumor multifocality. And also they calculated their metrics area under a curve that was 0.86 and 0. In the training set and 0.77 in the test set, respectively. And they developed an easy to use risk calculator tool that could be used online for this. And here were the risk factors that contributed. So, for example, transurethral resection, the TURBT, transurethral bladder tumor resection, and then bladder neck involvement, trigeminal prostate involvement, tumor multifocality, we already talked about this, lymphovascular invasion, and diversion type. So diversion is a surgical procedure to divert how the urine flows. So the type of this procedure was also important. Also concomitant carcinoma in situ neoadjuvant chemotherapy or adjuvant chemotherapy, and these were all significant predictors. And as we said, tumor multifocality and concomitant carcinoma in situ were independent predictors of their recurrence. And they developed an easy to use online calculator. So, like, a lot of words for a cool thing that can be used based on all the clinical information, all the patient data. So basically, you can have a machine learning model that calculates this. Maybe with an LLM, they didn't use large language model here, or at least they don't talk about it in the abstract. But what you could do, you could leverage LLMs, RAG, to get this information to the machine learning predictor and get the prediction without like having to input it manually, which would be fantastic. So here, go AI. And we have one more. Okay, our last paper for today, reticulin framework assessment in neoplastic endocrine pathology. I saw this title and I'm like, so cool, because you can do a special stain for reticulin and use image analysis, AI-powered image analysis, which is like my favorite thing to talk about. So this reticulin framework, this is composed of mainly type 3 collagen. It's a framework that holds the cells together. It's an essential structural component of biological tissues. And reticulin stains, specifically particularly silver-based methods, they enable detailed visualization of reticulin framework alterations. And I'm going to Google reticulin stain for you. And so now you should see reticulin stain. And you see this black stuff. So all this black stuff here is the reticulin. This is this type of collagen, type 3, that is stained with silver stain. Silver stain makes stuff black. So all this is reticulin. So I see that and I'm like, it's easy to see, meaning it's going to be easy for an algorithm to classify. So you've seen the reticulin stain, and it is a quick, low-cost, and reliable solutions for highlighting quantitative and qualitative changes of reticulin framework. So you can imagine you have this like regular framework where the cells sit on this framework, and if we have like disruption of this framework means cells are out of whack, which is kind of an unofficial definition of cancer where they start growing like crazy. So the framework is distorted. So this distortion of the framework, changes of the framework, have been variably associated with neoplastic and non-neoplastic conditions. So this is an overview of reticulin stain applications and reticulin framework assessment in endocrine and neuroendocrine neoplasms. And we're talking about the pituitary, parathyroid, adrenal, and some other neuroendocrine systems. And in pituitary neuroendocrine tumors, reticulin framework loss serves as a distinguishing feature between normal and neoplastic. So to me, it's already, let's make an algorithm for that. So between normal and neoplastic adenohypophysis. And then when we talk about parathyroid neoplasms, including adenomas, atypical tumors, carcinomas, and there is varying degree of reticulin framework disruption. And similarly, adrenocortical neoplasms. And so this reticulin framework is important for malignancy assessment as defined in the reticulin algorithm. So there's a reticulin algorithm, but it's not like a computer algorithm yet. This is something that incorporates the reticulin framework alterations along 3 WISE criteria, which totally could be a computational algorithm. Maybe it's already computational. My understanding was this is visual. So we check for necrosis, high mitotic count, which is over 5 per 10 millimeters square, and venous invasion to vein invasion of the cancer cells into the veins, and specific reticulin framework patterns help distinguish different morphological subtypes of bilateral macronodular adrenocortical disease. That's a mouthful that requires some work. Pheochromocytomas and paragangliomas display a range of reticulin framework patterns. Finally, different neuroendocrine neoplasms exhibit also variable reticulin framework integrity with a more significant disruption observed in high-grade carcinomas, and high-grade are more out of whack. So the reticulin is going to be also more disrupted. It's going to be all over the place. And here is my favorite statement. So maybe we can change color for my favorite statement is advancements in digital pathology and artificial intelligence offer promising avenues for automated reticulin framework quantification. And that would further improve our assessment of this. So I would like, if I was a researcher here, the next thing I would do would be to scan these images and develop an algorithm, maybe like a weekly supervised one. Let me unshare this. Okay. So I would do a weekly supervised where I would have the image of the tumor with the reticulin stain, and then the diagnosis or classification, malignant, benign, whatever you want to use this algorithm for, like a screening one, for example, malignant, benign. And I would train it and then run it on these stains. If they are cheap and used on a regular basis, why not? Let's have an algorithm do that. And these are all our publications for today. And if you're interested in the earrings, you can find them in the store digitalpathologyplace.com. There's gonna be some more stuff coming up, but I just thought it's gonna be nice to make them available for you. They are sparking conversation. And I don't think there's too much cool stuff from under the microscope in the jewelry department. And I always see like DNA, some protein jewelry, like the DNA helix is always on some necklaces and stuff, but nothing from histology. I thought that would be something that you might like. Thank you so much for joining me. And there's going to be histology workshop, histology live stream. So if you're interested in that, drop me a comment as well, even if you're watching the replay, if histology is something you want. And next, we're going to be reviewing the next papers. So honored and so happy for you to join. And I'll talk to you in the next episode.